Thank you for this opportunity to present our work. Today, I would like to talk about our review of 31 patients who underwent cholecystectomy to treat Xanthogranulomatous cholecystitis. First of all, we apologize for there being some differences between the content in this presentation and the abstract. Here is my disclosure statement. As we all know, XDC is a rare inflammatory gallbladder disease that is difficult to diagnose and treat. The purpose of this study is to evaluate the clinical and radiological features and surgical outcomes of XDC and to determine the appropriate treatment approaches. The characteristics of the 31 patients diagnosed with XDC were retrospectively investigated based on histopathological findings among 1,513 patients who underwent cholecystectomy over a 9-year period at the hospital. Either laparoscopic cholecystectomy or open cholecystectomy were performed based on preoperative findings. This table shows the characteristics of patients with XDC. The mean age of the patient was 71.7 years. Abdominal pain was observed in 18 patients, while jaundice was observed in 5. In the preoperative diagnosis, acute cholecystitis was observed in 11 patients. Chronic cholecystitis was also observed in 11. And suspicious gallbladder cancer was observed in 5. Gallbladder stones were observed in 28 patients, and CVD stones were observed in 12. Preoperative biliary drainage was performed in 21 patients. ENBD and EST were performed for acute cholangitis. PT-GBD was performed for acute cholecystitis. This table outlines the operative procedures and postoperative complications. Laparoscopic cholecystectomy was performed in 11 patients. Conversion to open cholecystectomy was performed in 12. Open cholecystectomy was performed in 4, and open cholecystectomy with gallbladder bed resection was performed in 2. Postoperative complications were observed in 3 patients. This table shows the rate of conversion to open cholecystectomy in XGC and other forms of gallbladder diseases. The rate of conversion to open cholecystectomy in XGC was 52.2%, but the rate of conversion to open cholecystectomy in other gallbladder diseases was 5.2%. XGC had a significantly high conversion rate. This table shows the characteristics of cholecystectomy procedures. 27 patients underwent cholecystectomy only. The average surgical duration of laparoscopic cholecystectomy was 130 minutes, but the conversion to open cholecystectomy was 185 minutes. Conversion surgery also resulted with a significantly greater volume of blood loss compared with laparoscopic surgery. This slide shows the characteristics of 5 patients with suspected gallbladder cancer. These patients had irregular or focal thickening of the gallbladder wall, and in some cases, the border between the gallbladder and the liver was unclear. FDG PET was performed on 4 patients, and all were positive. Interoperative frozen sections were obtained from 5 patients, and all were diagnosed with XDC. The case presented here is a 62-year-old male suspected of having gallbladder cancer. The patient was admitted to our hospital due to jaundice. Preoperative biliary drainage was performed after examination to investigate the cause of jaundice. Abdominal CT scans revealed diffuse thickening of the gallbladder wall, and intrahepatic bile duct dilatation, and the border between the gallbladder and the liver was unclear. MRI revealed diffuse thickening of the gallbladder wall, and T2 weighted imaging showed high signal intensity in the wall, suggesting abscesses. We could also see the stenosis of the CBD. Ultrasonography revealed irregular thickening of the gallbladder wall. FDG PET showed an abnormal accumulation in the gallbladder. The resected gallbladder was atrophied, locally thickened, and strongly adhered to the surrounding organs. Histopathological examination showed severe inflammatory cell infiltration and forming macrophage aggregate. This was diagnosed with XGC. By way of discussion, initial laparoscopic cholecystectomy to treat XGC is possible, but laparoscopic surgery is often difficult due to severe inflammation. Open surgery is recommended in patients with suspicious gallbladder cancer and in those with expected dense fibrous adhesions and excessive local inflammation. In conclusion, XGC may resemble gallbladder cancer based on clinical and diagnostic imaging findings. Laparoscopic cholecystectomy to treat XGC is possible, but is often difficult due to the presence of severe inflammation. Analysis of intraoperative frozen sections is useful to distinguish between XGC and cancer, and is important for avoiding unnecessary extended surgery. Thank you for your attention.